Cape has the lowest level of all provinces when it comes to poverty. Now, you also have a much lower percentage compared to the rest of the provinces when it comes to rural, the number of people you have in rural areas, which then leads other people to conclude that you have really no excuse to deliver the best services that the country has to offer.
Good evening, Vuyo. Good evening to the listeners. That would be debatable because whilst we might not have rural, but we have got the farm areas. For 5 districts within the farm where the distance are quite far from each other. For example, in the central Karoo, where you'll get probably 2 or 3 people in one area, and then we have to walk probably almost 10 or 15 or 30 kilometers for the next service. But I must just also highlight that the health systems throughout the whole provinces are under pressure because of the economy that is very low, which impact on the pricing of medicine. We also have got a population that has increased, and with a quadruple burden of disease in terms of the HIV, TB, diabetes, mental health, and maternal mortality, it affects all the provinces. Now what's happening is that you'll find that people are getting ill, people are unemployed, meaning that they don't have access to medical schemes in terms of to be insured. So they become the responsibility of the state. So in the Western Cape, yes, probably before then, but if you compare in terms of the population, 2011 census, we were about, I think, 5.3 million or so. Now we're sitting at about 6.5 million. And if you compare also that there is a lot of immigration coming from other provinces, the recent stats I saw that Eastern Cape, for example, this population has decreased by 8%, which is, we know that mostly the flow comes this side. And in addition to that, some of the population, sick people, they don't necessarily migrating, but in terms of the referral, going to the Tygerberg's, Grooteskier Red Cross Hospital, which is a national asset for anybody, and money doesn't follow the patient. So we do have challenges in the Western Cape as well.
So how do you ensure that the people who live in outlying areas, townships included, one must stress, do get the services and aren't discriminated against?
Actually, almost all our health facilities, they are in the where there are people needed. We don't have facilities in Bishop's Court. We don't have facilities in Clifton. All the facilities are meant for the uninsured population. We do have a hospital, for example, in Khayelitsha, brand new, about 300+ bedded hospital, new hospital, Mitchell's Plain Hospital, and Eerste Rivier Hospital in Helderberg, in terms of the people from Strand. So all our facilities actually, they are in the poor areas where people are needed. One hospital, for example, the New Somerset Hospital, which is around the waterfront, it doesn't service the people that are around waterfront. It's a level 2 hospital that services people as far as the West Coast. And it's the one actually that we need now to expand the services once we build the Clairefontaine one. That was for the replacement. So 75% of the population of the Western Cape, it's only for the poor people, because the others can use, for example, the private hospitals.
Now, an estimated 2 million people in the Western Cape are suffering from mental illnesses. But apparently less than 30,000 are in fact diagnosed or on treatment. So potentially, you have another life esidimeni waiting to happen there.
As I indicated earlier, that the health systems throughout all the provinces are under pressure. So what happened in Gauteng, in terms of the people who are in the NGOs, because I must just also highlight that there's nothing wrong for the mental health, depending in terms of the diagnosis that they could be able to access community mental health services. For example, in our case, we do have what we call step-down facilities for those patients who are in transition, who will have been discharged from, let's say, Falkenberg Hospital or Lendegier, and then they go via these NGOs that we fund as a step-down in transition before they go home. We do have such. There are also some patients which probably are unknown to they're not part of the health system, where, for example, the mental health user suffering from dementia, or children, maybe a child suffering from intellectual disability, who's not necessarily a patient, but probably the family takes that person to the NGO. The NGOs are generally registered by the Department of Social Development. And if the NGO has about 5 or more of the people who need, for example, a mental health facility, like as I indicated earlier, they need to be licensed by health. But in most cases, that you won't be able to know. But that's why at the time when we realized that we have got such a problem on our hands, where most of the NGOs will end up not going to be registered, because there's also issue of the municipal bylaws in terms of how they're supposed to meet the requirements, like to have a fire extinguisher, the rezoning, and all of this. So we have to undertake in terms of trying to get more information about all of those. But as I indicated earlier, there are many patients anywhere in South Africa where they are not necessarily known within the health system, because they are not necessarily patients who have been referred.
But what are you actively doing about it? Because Dr. Giovanni Perez of the Western Cape Metro District Health Services says the number of unlicensed non-profit organizations was 16 in like 2 weeks ago. It's now standing at 26. That should worry you, because from what he says, many of these non-profit organizations are springing up without the knowledge of the government.
Yes, exactly. That's what I'm trying to highlight, is that for those that we ended up knowing them, we make it a point that we visit them. And then we have got systems that are in place where we have to monitor and evaluate. We also do the spot checks, but some of them, they are not necessarily that are under the health system, because we won't know. So we rely also on the communities in terms of informing us. But for those that we pick up, for example, in December or early in January, we made a point that some of them, if they are licensable, we license them. And some of them, it's about progressive realization, where we have to monitor on close range so that to see that they meet the requirements. Some of them we have to de-license if they were, for example, they were licensed before. So it is a problem that is happening throughout. But remember, the case for acid Dimeni is completely different, in the sense that those patients were institutionalized, and then it was about now de-institutionalizing them. But you don't de-institutionalize when you put them in an NGO, because it's still an institution. So there are things, these things are complete different things.
Dr. Mbombo, thanks very much for talking to us this evening. She is the Western Cape MEC for Health.